Jens, who's going to be moderating the Deformity section, assigned me my talk, so I'm going to go next. And let me pull up my lecture. Let's see here. Okay, I think I got it. Thanks, Angela. So I'm going to talk a little bit about sort of, what I think is, and I think, the speakers today did a great job of kind of going over, the Holy Grail and being able to use technology and do deformity, have decreased complications, length of stay, all that stuff. And, I've been so lucky that I moved back home to Seattle, and I was able to be part of the Seattle Science Foundation from its beginning. And not just this course, but all the courses that we have. I've learned so much from all the speakers. In fact, I learned more from the speakers and the faculty, the participants, than I think I do anywhere else, any of the courses that we go to. And we have such a terrific group of staff here, and really you can't run these courses without having awesome staff. So the big guy in the picture, Gary Hawley, runs the lab and has been working with us for the last 16 years and has done a great job. He actually was in the OR, was working with all the docs here. Actually, we stole him from Tacoma and came up here, and he's just done a great job. And, the lab runs seamlessly. And then we've got Corey, Linda, Alexis with her infectious smile, and Ben back there who does all the AV and the tech work. And it's a small group of people, but, it's a really powerful group. And I do have to declare my disclosures, and I have my x-rays up here. I'm a big fan of lateral procedures, and I finally had my own lateral procedure this year, and I had a tibial plateau fracture in Montana, so it was quite the experience. But fortunately, Jens Chapman was available when I called him from the ER, and he looked at my CT and he said, "That does not look good. I think you need to have a lateral procedure on your leg." And these are my x-rays, so you can see they did a great job reducing the fracture. And it's amazing to me, and this is all in orthopedics, right? They used K-wires, they used all these, things that we do in spine, but they've been doing it long before we did. And then, even the screws, I love the fact that, this is the original kickstand screw, right? The one going all the way across. It's not the one we do in spine surgery, but it's unbelievable to me, like what you can do with instrumentation and just being a patient myself, I fully appreciate minimally invasive procedures. This was not minimally invasive, but
the robot helped, right? Oh, wait, they didn't use a robot. How
no,
could they do that?
And,
how could they do that?
And actually, the team at Harborview did a great job. And thanks again, Jens, and I've been fortunate to be around some really incredible and get to know all the surgeons in our community. So, so those are my disclosures. And going off kind of the theme today is technology, MIS, and really in my practice, we still we don't use a robot, but I use technology like crazy. We use navigation. We're very fortunate. We have, a lot of tools. We had the first intraoperative MRI, first O-arm in the city. We've gotten very close to getting a robot, and I think part of my resistance is, and I think Martin showed it, is, I kind of always viewed it as like this can kind of thing, and Izzy would always come here and talk about how great it was, and I just couldn't get over the can, but now it's way more than that, and it's unbelievable, what you can do. And here's some, nice pictures that we have, like using navigation. I use navigation like crazy. And again, just being around all these great minds at SSF and getting to spend time with the, I would say probably the godfather of, deformity and, just being around Professor Dubussé and, just his thought about how spine surgery should be done. He's a very thoughtful, eloquent surgeon, and really, what would drive him crazy is everyone would have all these algorithms, and he would go insane when he would see people measure, what is the, pelvic incidence, although he thinks it's important, the parameters, he would go nuts if you start drawing stuff, because for him, it wasn't just about measurements. It was about, okay, what is that one particular patient and what's their balance going to be? Because, maybe somebody who's 7 years old and tilted forward, maybe they're happy being in that position. So, he kind of turned this as the cone of economy. And again, for me, it's very challenging because you get patients like this, right, where they're tilted forward, and although their x-rays might look terrible, I mean, this patient actually was doing fine, didn't need to have surgery, didn't need to have, minimally invasive, didn't need to have any surgical procedure. But I do think, again, just not even doing, in the big picture and grand scheme of things, and I think Jens brought this up, is if patients do need surgery, I think as surgeons we have to be very thoughtful, and we have to be really, especially nowadays, you have to, if you're going to operate on someone like this, you really have to think about all the things that are important, right? Bone density, global alignment. What's this patient's age? They're 75. They're not on narcotics. They have osteopenia, osteoporosis, their BMI is not great. They're, like most patients I see in clinic, even though they're not diabetic, most of them are pre-diabetic. They have metabolic syndrome. They have all these, things. And once you start to peel the layers away, and what we've realized now is, look, muscle mass, sarcopenia, there's all these, things. Why is the incidence of PJK 30, 40% after these surgeries? Are these fixed, flexible deformities? Are you seeing someone in the early stages of Parkinson's? Do they have some little bit of dementia? Do they have vascular disease? What's their cardiac history? I think we really have to be thoughtful about doing these procedures and think about, what are the best options? Sometimes doing a big open surgery like this is really what needs to be done. I think we have to think about, okay, what is MIS? Is it placing, instrumentation? Is it putting guide wires in? Is it using navigation? And again, when I look at MIS surgery, and I've done a lot of it, is that, even the instruments today, if you look at all the companies that do percutaneous, let's just use percutaneous fixation, those instruments were developed for open surgery, right? And they added tabs onto it. Even the reducers, the rod holders, none of these things were developed for MIS procedures. So I think we got a long ways to go, and to me, that's exciting. There's a lot of development that needs to happen in this space. And when you look at a CT like this, it's amazing to me, even with CT technology. I use CTs on everyone. You can see here, if you look at this carefully, what do you see here? You see the paraspinal musculature, right? And if you're gonna plan the surgery, again, for me, a great MIS procedure would be to go lateral to the muscles and be able to place each screw in the pedicle. And just like all the great speakers today, Martin, Roland, Nuge, and, be able to harmoniously place these screws. And you shouldn't even have to really think about it. And you place the instruments and be able to realign the spine. And again, this is an MRI, but you can see this one is done open. The other one's been done MIS. So okay, we normally don't look at the muscles, but look at this. Why is it white? Well, because there's now fatty infiltration, there's scar tissue. So, ideally, you want to try to preserve the muscles if you can, if you're going to do a fusion. So these things, I think, again, sarcopenia in a 7-year-old versus a 50-year-old, these things do make a difference. And I think these are the subtle things we need to think about. And again, I don't have all the answers, but these are cases, for example, this is someone who's got a pretty bad deformity. And early on when I started doing a lot of MIS, and again, I wasn't using a robot, but you can really push the envelope and try to do something like this percutaneously. And now I've sort of gone the other way. And I think, Rick showed, I actually like to use one midline incision and put in the instrumentation and then go lateral and then try to get the fascia. Because I do think having 20, 30 incisions laterally is not that sexy. And it's not fun closing, and the patients aren't happy. So that's where I really got into doing lateral surgery, because I was like, look, and you really have to try to get anterior column support. And again, to try to get, especially because I was doing a lot of MIS surgery posteriorly, is how do you get the three-dimensional corrections, right? You have to try to attack the spine from the front. Otherwise, it becomes really challenging. But when I was starting to do lateral surgery, it was kind of, people were still trying to figure out the anatomy. I remember it was like 2006, 2007. I was in Virginia with Dr. Arlay, and Chris Shaffrey was there, and we were still doing open surgery and doing A-lifts, and I was like, this is such a cool approach. But as a neurosurgeon, no one really taught us how to do lateral surgery. It's something that you learned, and again, even for me, doing lateral surgery was, okay, there's all these new vascular injury, retroperitoneal space. You have to deal with the lumbar plexus. It's an area that, as a surgeon, we don't have a lot of exposure to. And the urologists certainly do, but not neurosurgery, not orthopedics. So spend a lot of time. And again, for me, if you're going to do anterior surgery, you're going to do lateral surgery, you have to understand these three-dimensional, very complicated structures and the anatomy, and all the textbooks at the time that were out. I mean, these are all not, this is not, this is Gray's Anatomy. That's not what the lumbar plexus looks like, okay? This is what it looks like. And, all the anatomy textbooks, if you look at them, they were always based on, 100-year-old drawings, and they weren't always correct. And so, again, having the ability to be here at SSF, this is a picture of Sven and Cliff, two of our fellows. The fellows we did all these dissections. We relearned, we had spent a lot of time in the lab here trying to figure out, okay, what are these relationships? What do things look like? We did 3D. This is a great 3D sort of depiction, and this is a cadaver, and it shows you the psoas muscle and the relationship to the nerves. And again, this is a picture of Jens and his cousin. They look similar, but, they have some subtle differences. Jens has a little bit more hair than his cousin, but, their lumbar plexus is going to be totally different. And two, the lumbar plexus is in women, men, it's everybody's got different anatomy. And we spent the last, 15 years, and finally we published this book on the surgical anatomy of the lumbar plexus. And, and again, it's through all these courses, all these cadavers that we did. It's a combination of learning from everyone here and really kind of understanding, that this is a new approach with new potential complications. And again, going back to my talk is, what's the best approach for someone like this? I don't have all the answers. I mean, the beauty of spine surgery is that, as you guys have seen, there's many different ways to do this. You could do an A-lift, you can do lateral, you could try to do this posteriorly, or potentially, maybe this patient doesn't need surgery. Maybe they don't need to have anything done. Obviously, they've had some cabbage done. They've had some vascular disease. I ended up doing, again, my go-to, and I think Roland brought this up, is, you got to do anterior column support, so either ALIF, lateral, and then try to do this percutaneously in the back. And I've had a hard time, and we don't have a robot, is, how do you get the pelvic screw, S1 screw, S2AI, how do you get this all to align, and how are you able to, feed the rod in? Again, most of the companies, they kind of do the MIS stuff after the fact, right? So they'll develop an open system, and then they'll just throw some tabs on, and they'll say, oh, the MIS guys will be happy now. We have an MIS. But that's not how it works, actually. You have to have special reducers. You have to have special instruments. You have to have rod holders that can turn the rod and be able to pass that rod from all the way to the top down to the bottom. So, and again, my go-to is to go lateral. I mean, that's kind of like my workhorse. So a lot of these cases I'll attack laterally, stage it, and then go posteriorly and place my instrumentation posteriorly. And again, a lot of these, are they fixed or are they rigid? Usually it's a combination of both. Most of these patients will have, their apex will, might have some osteophytes in there, so they might be fixed. And I do think we get CT scans on everybody, because it just gives you so much information. So everyone gets, a lot of scans, and here's before, here's after. Again, you can see that it's not perfect alignment, but it's not bad considering where we started. And here's some more. You can see how much three-dimensional coronal correction you can get just by going lateral. But you have to understand, the anatomy and the thoracic spine, the diaphragm, thoracolumbar junction. Here's another case where, again, I think patient selection is super important. That's what's going to ultimately drive all this, right? I mean, regardless of the technology, if you use navigation, you do whatever. This patient ended up having. This was done, this is a patient that was sent to me, and this is what they ended up having done. And, I mean, you really have to, I think technology can be helpful, but it can also be dangerous. And again, this patient was done, it was done with navigation, and this was the end result. So I think as surgeons, we really have to be conscientious. We have to be thoughtful. This is a patient that I did laterally. You can see how much correction you can get just going laterally. And I didn't, I was planning on trying to do this percutaneously, but during the operation, we converted it to a open procedure, and this was our end result. So, I think you have to be flexible, and you have to be open. And I learned a lot in the last, 20 years. And fortunately, again, like I said, I've learned a lot from going to courses and being being surrounded by people like today in the room. And I think what's exciting to me is I think there's just so much going on in this space that I'm excited to see what the next 5 to 10 years is going to look like, because I think these surgeries are all going to be, placing the screws is going to be an afterthought. It's all the other stuff that goes into it. It's the pre-planning, who gets surgery, who doesn't. I mean, it's amazing to have all these, I think eventually we're going to put in all the parameters of the cases, and then our algorithm to say, okay, you know what, the risk of having a PJK or this because of the bone density, their age, their muscle mass index, and it'll give you like a statistical an analysis and say, okay, this patient's not getting surgery, so thanks so much.
This is a great intro, and in the interest of time, move ahead.